back, new abstract, again, talking to Aaron Goodman, Manni Mohyuddin. Ixazomib plus Lendex versus Lendex maintenance after auto stem cell transplant. This is the results of the Spanish study. Aaron, this is a provocative abstract out at ASH. I wonder if you might summarize, what did the authors do in this study? What was this second randomization all about?
Yeah, so we're going to talk about Ixazomib, Ninlaro, one of my favorite drugs, all oral proteasome inhibitor. So what
that means it's better, right? If it's oral, it has to be better. But I've heard.
More convenient. And with Rev, you could take all the maintenance oral. It's great. So they took transplant eligible patients who got VRD induction, and then they went to autologous stem cell transplantation. And then they randomized these patients to Ixazomib, Revlimid, Dex versus Revlimid, Dex, which is Revlimid. That's fair. We're using Revlimid as our maintenance strategies in the United States and elsewhere. What they found was, I usually criticize 3 versus 2 studies, or now with 4 versus 3, because when you add an active drug in myeloma, Ixazomib does have some activity. I won't argue against that. And if your endpoint's PFS, I suspect the addition of an active drug is going to enhance the progression-free survival. And other times I've mentioned that in the maintenance setting, truly the only endpoint, I'm firm on this, that matters is overall survival if you're going to give a drug indefinitely or for a long time. And so they did this 3 versus 2, and I would not have been surprised if progression-free survival was longer, nor would it have changed my practice. But they did the study, and actually there was no increase in progression-free survival. It was the same, and there was more toxicity giving the Ixazomib. I just want to point out a few other things with this drug, Ixazomib. So the initial Tourmaline 1 study, which looked in the relapse setting, was IRD versus RD in the relapse setting. And it did show a progression-free survival advantage, but long-term follow-up just published, I believe, in JCO, still showed no overall survival advantage to IRD versus RD. The Tourmaline 2 study, which looked at IRD versus RD in transplant-eligible patients, transplant-ineligible newly diagnosed patients, showed no statistically significant benefit to PFS with Ixazomib. And then as the in the MM4 study, the Tourmaline 4, which was in the non-transplant setting, continuing Ixazomib maintenance versus placebo, also did not show any benefit, and perhaps even a risk of increased death. So we have now a lot of data, including this most recent study, showing that Ixazomib does not do that much.
That is really sobering, because I would have shared your intuition that I would have thought PFS, if anything, was a chip shot for Ixazomib. Of course it was going to do it. It didn't do that. Surprises me. Manni, what are your thoughts on this trial? What are your thoughts on Ixazomib?
Yeah, so great question. So I think this should hopefully, at least in my mind, be the final nail in the coffin for Ixazomib. It, as Aaron has very eloquently pointed out, trial after trial has either been negative or has been a very marginal benefit for Ixazomib. I think the consensus and of all the evidence, if you look at it, is that Ixazomib is a weak PI. It has some activity, but that activity has probably very little clinical meaning. And I think that it should sort of make us reevaluate the trials that we are using Ixazomib in. Like there is an ECOG trial currently that is going on that is randomizing patients that are MRD positive after a transplant to either lenalidomide plus placebo or lenalidomide plus Ixazomib. So, I mean, that trial has been enrolling now for a while, but it just goes to show that Ixazomib is still, they're still trying to find a niche where it can be studied. And I think that by and large, Ixazomib should not be used. And if you really have to use an all oral regimen, then you should have a very frank conversation with your patient about, how much incremental benefit you think Ixazomib is adding, because it does add toxicity. In practice, when I've given it, or when I've seen it being given, it has caused, significant GI issues. It's not a benign drug by that means. So I think this should be an inflection point where we look back and we're like, okay, we probably shouldn't be using a lot of Ixazomib moving forward.
There's no role, in my opinion. I mean, the Tourmaline 3, which was Ixazomib versus a placebo post-auto, when we know clearly that Revlimid is what we should do, showed a very modest increase in PFS. So I would never use it as a maintenance post-auto. We have a better alternative with a better endpoint. And then the other positive study, the initial Tourmaline 1, which was in the relapse setting with RD, either as a fluke or, again, very modest. And we have much better other regimens that we would use in the relapse setting. So I see zero role. And I know this argument for convenience. Well, if it's convenient, you know, if it doesn't work and hurts you, who cares if it's convenient? You know, it doesn't really add much.
There's no quote from the Princess Bride's going to save Ixazomib. But here's my question for you, gentlemen, a tougher question, okay? There are other settings where we lean on proteasome and Revlimid maintenance, but we don't have robust randomized controlled trials showing that that has an improvement in overall survival. Is this an indictment of PI Revlimid maintenance in other settings, which has been taken forward without robust randomized trials showing overall survival? Manni, you're shaking your head no. You don't hold this against other proteasome inhibitors. Go on. Why?
That is correct. So, you know, there was the closest parallel to this is the Forte trial, which was evaluating carfilzomib. The second randomization of the Forte trial, which was after an auto transplant, patients were randomized to either Revlimid alone or Revlimid plus carfilzomib. In that study, there was a clear PFS advantage with carfilzomib plus Revlimid versus Revlimid alone. So it's similar. There's some parallels between this the study we're discussing now and the Forte study, but obviously carfilzomib is a more effective drug. It's shown a PFS advantage in this situation. You are absolutely right that for maintenance, the onus is to show an overall survival advantage. So long-term follow-up will be telling, and I hope
one point about Forte just doesn't have the power to get you there. It's an underpowered phase 2. I wouldn't hang my hat on that OS, even if it's positive. What do you say?
It is. So it is a phase 2. It is a large phase 2. So it's larger than some studies that we call phase 3. I believe like the number of patients is like 400 or something. It's a large phase 2. And it makes me think about what sort of numbers we use to call studies phase 2, because that smoldering myeloma trial, that's like less than 100 patients. And that's called a phase 3 study, the one that, was done in Europe a long time back. But you're right. I mean, but I'd say that it's a decent sized trial with at least it's powered for PFS. The endpoint of the second randomization was PFS. But I think time will tell. But I do think that for high-risk patients, I acknowledge that there's no overall survival advantage. But on a case-by-case basis, you can consider using carfilzomib or using Velcade plus Revlimid. But yeah, you should not be using Ixazomib in those situations.
All right, after this discussion, you're going to go ahead and email me that phase 3 study that supports Velcade. Just go ahead and send that to my email.
There is no phase 3 study. There is no phase 3 study. But I think Velcade but we just discussed this. But Velcade and carfilzomib are fairly interchangeable in my mind for newly diagnosed and for probably in the maintenance setting. But you're right.
Transitive property to the test in my mind. Aaron, closing thoughts.
I was going to say classic oncology. Bad disease, high-risk cytogenetics, they do bad, and we want to do more. It's human nature. We want to help these patients. As we've seen now with EPOC and DLBCL, CNS prophylaxis, all these things, we just these things we think are helping are good chance they're not, and they're hurting. So I understand this enthusiasm to give more maintenance, more intensity, but we really need the studies, especially with we're prolonging the survival, if we're going to take patients and make them come in every few weeks for a proteasome inhibitor indefinitely.
Thanks for doing it, gentlemen.